that's why we had to shift the time from 3 to 5 p.m. so that 5 p.m. Nigerian time to accommodate his presentation. I want to thank him for accepting to make this presentation, and the topic will be home oxygen in the golden half hour, a breakthrough for the prevention of sickle cell crisis. We'll hear more about that when he makes his presentation. So without wasting time, I would like to call on Dr. Omoigui, the chairman of the guild, to say one or two words before we start. Over to you, sir.
Okay, thank you very much, Dr. Eletu. I join Dr. Eletu in wishing everybody a happy new year. And this is our first meeting this year. And I want to welcome heartily all those who have joined us so far. I expect many more people to join us. And also to welcome in particular the lecturer for today, Dr. Sota Omoigui, all the way from North America. And we also have the pleasure of having as our moderator the immediate past president of the Pediatric Association of Nigeria. The topic for today is a very important one because the subject of sickle cell disease is always important in this part of the world because of the sheer burden, the volume of the burden of the condition here. And so from the point of view of clinical management of the patient, and also from the public health perspective, because the title, the topic that we have for today is something that is capable of of changing practice and therefore affecting policy. So it's a very, very important topic that should be of interest to all of us, all pediatricians and all health workers, really. And so we have no better resource person to discuss it than someone who has published on this particular topic. And so I am very keen and very eager to listen to him and to the discussions that will follow it. So I welcome the lecturer especially, and I welcome every one of us who is present. I've not been able to look through the list, but I'm sure before the end of the meeting or at the end, we will recognize everyone accordingly. So thank you very much, everyone. I look forward to a very, very useful 1 hour. You are talking of golden half hour. We have 1 hour here that I believe will be golden too. So thank you very much. Over to Dr. Eletu.
Very much, sir. Professor Grange has joined from the US. I want to welcome her formally as well. So I will hand over to Dr. Olufemi Ogunrinde, who is a hematologist from Ahmadu Bello University, the only university in Nigeria, as the moderator. Femi, over to you.
Thank you very much. I hope I'm audible.
Yes, you are.
Yeah, so good afternoon. Let me start by greeting the chairman of the Guild of Pediatricians in Private Practice, my well-respected elder, Dr. Femi Bolajilawa. And I also caught a glimpse of Professor Adenike Grange. And Happy New Year to both of you. Good afternoon to all distinguished members of GIPP, including my good friend, Sandy Eletu. I feel particularly honored being asked to moderate this session, especially when I consider the powerful membership of GIPP and the fact that the speaker in today's grand rounds webinar is an alumnus of the Medical School Ibadan, from where I also graduated. Well, let me start by saying kudos to Omoigui, Dr. Omoigui Sota. Let me call you Sota because I'm sure that many years ago we were friends in Ibadan. Maybe time has erased some memories. I say kudos to you for all the fantastic work that you have been doing in various areas of medicine, including pediatrics and anesthesia, and also your contribution to national development at various levels, even though you are across the Atlantic Ocean.
Thank you.
I had some challenges when I was told that I had to moderate this session, preparing an introduction for a well-accomplished gentleman like you. So I had to glean some materials from another accomplished academician, Dr. Yinka Migodun, the professor of psychiatry at the University of Ibadan. So by way of introduction, Dr. Sota Omoigui, alongside Professor Babatunde Ogunaike of blessed memory, and 9 other Nigerians were bestowed with the Citizenship and Patriots Awards as part of Nigeria's 63rd Independence Day celebration by President Bola Ahmed Tinubu. That was in 2023. Professionally, Sota attended the one and only King's College, Lagos, the one and only medical school, Ibadan, later transformed to a medical college. He graduated in 1983, a graduation that I did not witness since I left 2 years earlier. Sota then moved to the United States in pursuit of further academic and professional quest. Dr. Omoigui embarked on a diverse and distinguished career in medicine, focusing on pediatrics, anesthesia, and pain medicine. He honed his skills and expertise through an internship in pediatrics, a residency in anesthesia, and a subspecialty in pain medicine and regional anesthesia, all at Cook County Hospital in Chicago. His commitment to excellence led to his board certification in anesthesia, with a coveted subspecialty at certification in pain medicine. Beyond his clinical accomplishments, Dr. Omoigui has made significant contributions to the field of pain pharmacology, anesthetic pharmacology, inflammation, and inflammatory responses. His renowned drug handbooks are published in 6 languages and used by specialists worldwide. In the year 2007, Dr. Omoigui proposed a groundbreaking theoretical law on inflammatory origin of pain, which has been cited extensively in the medical community, further cementing his reputation as a thought leader in the field of medicine. His passion for democratizing medical practices has led to pioneering techniques that make spinal pain treatment more accessible, ensuring that primary care physicians, physician assistants, and nurse practitioners can provide effective care. Therefore, Dr. Omoigui can be described as a pediatrician and an anesthetist rolled into one, with subspecialty training in pain medicine and regional anesthesia. If I were to go through all these accomplishments, this webinar will turn into another exercise. So let me just mention that Dr. Omoigui is a true giant in medicine. He holds patents for groundbreaking inventions, including the US. Let me mention that I learned that he holds 5 United States patents for an app called Exchange Mall Super App. He's a co-author, and I'm sure we must have heard about this. He is a co-author of the recently replaced national anthem, Arise, Compatriots. And he has done extensive work in sickle cell anemia, like we are told, and he's here today to educate us on some of his discoveries regarding the early management of sickle cell crisis. Please, let us welcome Dr. Sota Omoigui. Sota, you have the floor and audience for the next 45 minutes. Thank you. Over to you.
Thank you.
Sota.
Thank you very much for your introduction, and welcome everybody. Good morning, good afternoon, good evening, wherever in the world you are in. And Happy New Year to everybody also. So I'm going to share my slides and we're going to get this presentation going.
Sorry, just to say that people can drop their questions in the chat box so we can have them presented at the end of the lecture. Thank you very much.
Yeah. Okay. Can everybody see my screen? Can everybody see my screen?
Yes, we can.
Yes,
we can see it.
Okay, thank you. Okay, the title of this presentation is Sickle Cell Crisis, Prevention and Treatment in the Golden Half Hour. Let oxygen be your medicine. The recorded history of sickle cell goes back 7,300 years. And I'll be presenting a video that shows that. The sun. So I'm going to play.
Recipient of the U.S. FDA Advisory Committee Service Award for service to the people of the United States of America, discovered and unveiled the first new intervention in 100 years of modern medicine and 1,000 years of human history that is 90% effective in preventing and aborting a sickle cell crisis within the golden half hour. The sickle cell mutation can be traced back to at least 7,300 years. The first recorded cases of sickle cell disease were in Egypt during the pre-dynastic period, about 3,200 BC. In the Persian Gulf during the Hellenistic period, 2,130 years before present, and in Ghana in 1670 AD. For thousands of years, sickle cell disease has been an inevitable sentence of recurrent excruciating pain crisis, resulting in complications, severe disabilities, and death. But Dr. Omoigui's discovery has come to offer a solution to a problem that is 7,300 years old. As Hippocrates stated in 400 BC, "Let food be your medicine," Sota Omoigui MD declares in 2024 AD that the guiding principles in the management of sickle cell disease shall be: let oxygen be your medicine, whether provided by inhalation or at the molecular level. Dr. Sota Omoigui's discovery, the science and the solution. History. Sickle cell disease was first described by Herrick in 1910. 1927, Hahn and Gillespie suggested that hypoxia or low oxygen caused the sickling of the red blood cell. 1930, Scriver and Waugh had blood may be varied by the change of the partial oxygen, O2 pressure. That this is a reversible reaction. Red blood cells need to squeeze through pores. Once oxygen brain. The reversible sickle cells can revert to their original flexible discoid shape when reoxygenated, but repeated sickling can damage the cell membrane and make
Sorry, Dr. Omoigui, the clip has finished.
It has finished?
Yeah.
It hasn't finished.
Ah, well. I can't see.
We are no longer seeing the video.
Yeah.
Would you like to, do you mind sharing it again? We are not seeing the video anymore.
You are not saying it again? Okay, hold on. Let me go back.
No video, no voice, really.
Okay, you were not able to see the video. Yeah, I got a notice that it unexpectedly quit. So hold on, please. Let me see if it can reboot. Okay, are you seeing my screen again?
Yes, you can see the screen, but not the video clip.
Yeah, hold on.
Revolutionary Discovery in the Prevention and Treatment of Sickle Cell Anemia Crisis. By Sota Omoigui, MD, Hawthorne, California, author, The Inflammation Theory of Pain. On July 4th, 2024, Dr. Sota Omoigui, a recipient of the US FDA Advisory Committee Service Award for service to the people of the United States of America, discovered and unveiled the first new intervention in 100 years of modern medicine and 1,000 years of human history that is 90% effective in preventing and aborting a sickle cell crisis within the golden half hour. The sickle cell mutation can be traced back to at least 7,300 years. The first recorded cases of sickle cell disease were in Egypt during the pre-dynastic period, about 3,200 BC. In the Persian Gulf during the Hellenistic period, 2,130 years before present, and in Ghana in 1670 AD. For thousands of years, sickle cell disease has been an inevitable sentence of recurrent excruciating pain crisis, resulting in complications, severe disabilities, and death. But Dr. Sota Omoigui's discovery has come to offer a solution to a problem. That is 7,300 years old. As Hippocrates stated in 400 BC, "Let food be your medicine," Sota Omoigui MD declares in 2024 AD that the guiding principles in the management of sickle cell disease shall be Let oxygen be your medicine, whether provided by inhalation or at the molecular level. Dr. Sota Omoigui's discovery, the science and the solution. History. Sickle cell disease was first described by Herrick in 1910. 1927, Hahn and Gillespie suggested that hypoxia or low oxygen caused the sickling of the red blood cell. 1930, Scriver and Waugh in Canada reported that the number of sickle cells in the blood may be varied by the change of the partial oxygen, O2 pressure. That this is a reversible reaction. Red blood cells need to squeeze through pores that are only 4 microns wide. When oxygen is removed, some of the cells sickle and get stuck. Once oxygen is reintroduced, the unsickle process occurs, and the cells now flow normally through the pores. Reversible and irreversible sickle cells. Reversible sickle cells, RSC, can become irreversible sickle cells, ISC, after repeated episodes of sickling with damage to the cell membrane. The reversible sickle cells can revert to their original flexible discoid shape when reoxygenated, but repeated sickling can damage the cell membrane and make it impossible for the cells to return to their normal shape, becoming irreversible sickle cells. Oxygen therapy in the golden half-hour onset of a crisis restores reversible sickle cells and prevents them from progressing to a critical mass of irreversible sickle cells, wherein the sickle cell crisis becomes established and intractable. Developing a medication to prevent and stop a sickle cell crisis within the golden half-hour has defeated the best medical scientists, the best and most resourced pharmaceutical companies, and the best researchers worldwide. The efficacy among Dr. Sota Omoigui's patients has been 90% for prevention and aborting a crisis in the golden half-hour. And when you stop the crisis, you prevent the severe pain, emergency care, hospitalization, and multi-organ damage. Should you miss the opportunity to abort the crisis in the golden half-hour, subsequent administration of oxygen in a hospital has no effect on the irreversible sickle cells. It just prevents any reversible sickle cells from progressing to irreversible cells. So it only helps to a limited extent in an established crisis. The irreversible sickle cells have to be removed by the body through the process of hemolysis, phagocytosis, or sequestration. It is also necessary to address other factors that may have initiated or are now aggravating the crisis. Most common of which is infection, including malaria, pneumonia, etc. References for more information, consultation, or to arrange presentations, contact Dr. Sota Omoigui by email at medicinechief@aol.com.
Okay, thank you. I'm going to proceed back to the presentation after that video. So let's talk about the underlying pathology of sickle cell disease. The sickle hemoglobin has a low tolerance to hypoxia. And hypoxia, for those members listening in who are lay public, means a low oxygen environment. And in the presence of a low oxygen environment, the sickle hemoglobin undergoes what we call polymerization, changes shape to a sickle shape. Now, very important is that the initial sickling is reversible, but in the absence of oxygen, can progress to irreversible sickling, which is cell damage and cell death. The reversibility of this initial sickling is with reoxygenation. So if you miss that golden half hour, whereby the reversible sickling can be restored back to normal, then the reversible sickling progresses to an irreversible sickling, which no longer responds to oxygen, and wherein you have damage to the cell membrane and cell death. Now, this is a basic flow chart showing the various pathways to tissue hypoxia, which progresses to reversible sickling first. Most common of which is exhaustion, fatigue, nocturnal hypoventilation. Nocturnal hypoventilation occurs during sleep because breathing is a little bit shallow during sleep. It doesn't matter whether the sleep is in the daytime or it's at night. But this is where the vast majority of crises occur, during sleep. Other causes of hypoxia include cold, air travel, altitude, excess heat, dehydration, alcohol by increasing sedation. So from this tissue hypoxia, you move into the sickling phase. Now, we also have, if you see below in the orange, other causes of tissue hypoxia, which include infection, malaria, and these act by increased cytokines, increased leukocyte, white blood cell adhesions, and slowing of the transit through the microcirculation. But these are not as common as the ones on top. So now, when you progress to reversible sickling, home reoxygenation in the golden half hour will restore these reversible sickle cells back to a normal discoid shape. And you can prevent and stop the sickle cell crisis. Now, what happens if you don't stop the sickle cell crisis? The reversible sickling progresses to irreversible sickling with cell damage. Those cells then die. You have cell death. They obstruct the blood flow. That's vascular obstruction. You have an inflammatory cascade resulting from the cell death. And now you've entered the zone of morbidity and mortality. Because from the cell death, the vascular obstruction, you now have organ damage. First of all, severe pain due to ischemia. The body is going to try to clear the obstruction from this sickled hemoglobin. And how does it clear the obstruction? It needs to destroy the cells and remove them. That process is called hemolysis, phagocytosis, as well as sequestration. And what does that end up causing? Destruction of the sickle cells causes a decrease in hemoglobin and severe anemia. So now it becomes like a cat chasing the tail. We are now chasing treatment of complications. From the severe anemia, it goes to blood transfusion. Otherwise, you have death. From the ischemia, it goes to severe pain. And here is a very important factor. Control of pain is critical to stopping the crisis. Because if you do not control the pain properly, you're going to have chest splinting, you're going to have shallow breathing, and the consequences of that is more hypoxia, infection in the lungs, give you an acute chest syndrome, lung damage, and death. Almost 25% of the mortality in sickle cell is from acute chest. And so when I'm talking about pain control here, I want to specifically mention that drugs like pentazocine or tramadol should be considered malpractice when used for the treatment of a sickle cell crisis. Because a drug like pentazocine has a ceiling effect. It's an agonist antagonist and cannot control the pain of a sickle cell crisis. You are heading towards an acute chest syndrome if you don't provide adequate pain control. So what should you provide? Pure opioids like pethidine, morphine, hydromorphone. And sometimes you can use ketamine, very low doses, 5 milligrams of ketamine, like 0.1 cc. Failure to control pain leads to a whole sequela of problems that end up in multi-organ damage and death. So now, the key thing in this home reoxygenation is that if the patient is not able to stop the crisis and reverse the crisis in the first 30 minutes, something else is going on, which will be the infection or the malaria. But 90% of the time, the crisis can be stopped as long as you control for the other triggers. So let's move on to the next one. And this information is based on 100 years of research that initial hemoglobin S sickling is reversible with reoxygenation. And when time progresses, they become irreversibly sickled. They get damaged, they die, they create an inflammatory reaction, and they obstruct blood flow, causing severe pain and organ damage. I'm going to play a video here from MIT about the behavior of sickle cells. So hold on, please.
Revolutionary discovery in the prevention and treatment of sickle cell anemia. So these are, and how you need to cut through time instruction in the microcirculation. And oxygen is removed,
can see those cells sickle and get stuck. Essentially, those cells are dying. But once oxygen is reintroduced, they are resuscitated. So the key thing is to resuscitate those cells before they become irreversible and die. Because once they die, it's of the vessel and ischemia of the organ. This video was produced by MIT in 2015 as a way of evaluating the effectiveness of anti-sickling drugs. I'll come back to the presentation now. So let's go through the history of sickle cell. In 1910, sickle cell disease was first described by Herrick by observing sickle-shaped cells in the blood of a dental student. In 1927, Hahn and Gillespie suggested that hypoxia or a low oxygen environment caused the sickling of red blood cells. In 1930, Scriver and Wow in Canada reported that the number of sickle cells in the blood may be varied by the change of the partial oxygen pressure, and that this is a reversible reaction. And then let's continue. In 1983, Frank and Chu stated that deoxygenated reversible sickle cells possess the ability to readopt their normal discoid shape upon reoxygenation. And in 1991, 8 years later, Robert Hebel stated that the phospholipid can traffic between the monolayers of the cell membrane. And deoxygenated induced sickling causes an alteration of the phospholipid organization. And for reversibly sickled cells, this destabilization is reversible. And in 2015, we watched a video by Melanie Gonick in MIT about reversible sickle cells and reoxygenation. Now, you wonder, has there been a clinical trial? Yes, there has been a clinical trial. In August 1992, Zipuski et al. In Toronto, Canada, studied the effect of oxygen therapy on the number of irreversibly and reversibly sickled cells in patients with sickle cell anemia. And they found out that inhalation of 50% oxygen in patients who were not in a crisis produced a significant fall in reversible sickle cells and a lesser fall in irreversible sickle cells. And in patients who were in a crisis, it showed a significant reduction in reversible sickle cells, but not in irreversible sickle cells, which means those cells were already damaged. Oxygen wasn't going to bring them back. In a group of patients that received air, no supplemental oxygen, there was no significant change in reversible sickle cells. So what this shows is that when the patient is already in a crisis, there's no impact on irreversible sickle cells. And that's why there was no significant difference between the air and oxygen groups in the duration of severe pain, opioid administration, and hospitalization. And this is why the title of this is Home Oxygen, because it's during the critical golden hour that there is an opportunity to reverse the crisis. By the time the patient gets to the hospital, it's too late. all oxygen will do will be to prevent some reversible sickle cells from progressing, but the irreversible sickle cells are gone. They are dead, and you're in the cascade of morbidity and mortality. So as mentioned, oxygen therapy, when a sickle cell crisis is already established, does not affect the population of irreversible sickle cells. These have to be cleared by destruction. Are you still seeing my screen? I hear somebody talking.
Yes, we're seeing your screen.
Okay. Okay. So please mute your computers or cell phones. So this is the cause in a drop in hemoglobin, because those irreversible cells have to be destroyed to clear the passage and causes severe anemia. So when there's repeated episodes of sickling, the reversible sickle cells become irreversible. But you have a time window when those reversible sickle cells are reoxygenated, when they go back to normal. And that's why in 2024, I published that oxygen therapy in the golden half hour, the first 30 minutes onset of a crisis, will restore reversible sickle cells and prevent them from progressing to a critical mass of irreversible sickle cells, wherein the sickle cell crisis becomes established and intractable. So if we can reverse the low oxygen environment by providing home inhalation oxygen that the patient can use within the first 30 minutes of a sickle cell crisis, we can stop the crisis. And when you stop the crisis, you prevent the severe pain, hospitalization, and multi-organ damage. So why did we miss this solution in the last 100 years? Because by the time the patients seek medical care or arrive in the hospital, they are already experiencing irreversible sickling that can no longer be reversed by oxygenation. Time-dependent golden half-hour intervention for a sickle cell crisis is similar to that of the golden hour for stroke, when there's the best chance of restoring blood flow and saving brain tissue, or for that of a myocardial infarction, where timely intervention impacts a patient's survival. And you will note that when we're talking about stroke, it's a single organ, the brain. Myocardial infarction is a single organ, the heart, whereas sickle cell is multiple organ damage. In my clinical practice in California, we've been able to reduce the incidence of sickle cell crisis as well as reduce hospitalizations by 90%, simply with home oxygen. The sickle cell crisis, where you have irreversible sickle cells, results in obstruction of blood flow, severe pain and suffering, and damage to organs. It results in severe life-threatening and disabling complications, including acute chest syndrome, a vascular necrosis of the hip, death of bone, which is death of bone tissue due to lack of blood supply. All of these complications are due to ischemia, lack of blood supply from obstruction. Stroke, brain damage, priapism, kidney damage that may result in dialysis and increased risk of death. So we must shift our paradigm to prevention or stopping the crisis, not waiting for the patient to get to the hospital. We can do this 90% of the time. Now, 10% of the time, when you have severe infection, malaria, then those patients will need to seek medical attention as soon as possible. Now, when and where do the majority of crises occur? They occur in a low oxygen environment during sleep. Please mute your mic, mute your mic. It occurs in a low oxygen environment during sleep. Because during sleep, there's shallow breathing, there's nasal vascular congestion, reducing airflow in the supine position. And majority of patients with sickle cell disease are afraid of going to sleep because they did not understand what was happening. In fact, there was an article in CNN and the New York Times where one of the patients said she thought there was a demon that came between 2 a.m. and 5 a.m. to give her terrible pain. It was no demon, it was nocturnal hypoventilation. In 2003, Hargrave et al. Concluded that low nighttime oxygen saturation was highly significantly associated with a higher rate of painful crisis in childhood. And last year, 2024, Chang et al. Found that 43% of sickle cell patients, almost half that they studied, had sufficient nocturnal hypoxemia to warrant oxygen therapy. They concluded that oxygen therapy may decrease inflammation and oxidative damage in hypoxic individuals. Now, what are the aggravating factors for a low oxygen environment? When there are one or more triggers like increased anemia, pain, stress, fatigue, exhaustion, infection, increased sedation, alcohol ingestion, altitude greater than 2,000 feet, cold environment, which slows the transit through the blood vessels, and the feeling of being unwell. In the absence of triggers, patients with sickle cell disease do not have to sleep with oxygen. But if there are any of these triggers, they should put on the nasal cannula oxygen and sleep with it. But should they not sleep with it and they wake up in a crisis, they should immediately turn on their oxygen cylinder or concentrator and apply oxygen within the golden half hour to abort the crisis. Now, what's the proof of concept of using oxygen? The disease burden of sickle cell anemia improved with the advent of medications like hydroxyurea and voxelotor. These medications target the availability of oxygen at the molecular level to the sickle hemoglobin. Once again, we mention oxygen. Hydroxyurea increases hemoglobin F production in red blood cells and decreases sickling of hemoglobin S. Hemoglobin F evolved to potentiate the transfer of oxygen from a mother's blood to a fetal tissue, a goal achieved by the higher oxygen affinity of hemoglobin F compared to adult hemoglobin A. Oxbryta voxelotor increases the affinity of the sickle hemoglobin for oxygen by thereby inhibiting sickling and reducing the amount of hemolysis and increasing hemoglobin levels. Now, Oxbryta was recently withdrawn by Pfizer, and I believe that because they had incidences of infection, and it did not prevent or stop a crisis. However, Oxbryta can raise the hemoglobin level of a person with sickle cell anemia by 2 to 3 grams per liter within just a few days, and in some cases can return hemoglobin close to normal levels, almost as fast as a blood transfusion, and without the possible complications. Now, what's the negative proof of this concept? We have a $665 million drug, Adakvil. Now, it's a humanized monoclonal antibody against P-selectin, which inhibits the adhesion of sickle erythrocytes and leukocytes to the endothelium. It was approved by the FDA in November 2019 for reduction in the frequency of vaso-occlusive crisis. However, the drug has been withdrawn from the market. It went through all the randomized controlled trials, all the bells and whistles, got approved. Well, when it reached the real world, it failed. It was revoked by the Europeans in May 2023 and by the UK on January 10, 2024. Why? Because the patients on Adakvil had more crisis than the patients in the placebo group. Average number of crises requiring treatment was 4.7 in Adagvio compared with the placebo's 3.9. And why did this drug fail? Because it was addressing the downstream inflammatory cascade after the irreversible sickle cells have already died. Whereas a $20 oxygen gas will prevent the reversible sickle cells from going into irreversible sickle cells. $20 compared to a $665 million drug. Now let's talk about air travel on high altitude. Air travel is a hidden danger for sickle cell patients. And it's your duty as physicians to make your patients aware of the danger. During and following commercial airline flights, patients with sickle cell disease are known to have experienced complications such as bone pain, splenic infarction, avascular necrosis, and in some cases, prolonged crisis resulting in death. And in fact, some patients have died in the aircraft. These complications have been linked to prolonged oxygen desaturation at high altitudes, with oxygen saturations measured as low as 77% instead of the normal 95 to 100%.
This, have less than 10 minutes, please.
Okay. The saturation begins within 10 minutes of the aircraft taking off. Now let's address treatment of a crisis. Time is of essence to abort the crisis before severe pain produces chest splinting, inadequate respiration, further hypoxic sickling, and a prolonged crisis requiring hospitalization. Where available in countries where you can have an ambulance administer to a patient the first dose of opioid and anti-inflammatory injection that the patient has previously tolerated. Now, take a note, opioids alone do not have the full effect. Opioids must be combined with an anti-inflammatory. In Nigeria, you have diclofenac. In the United States, we have ketorolac. Do not use weak opioids like pentazocine or tramadol. They are ineffective and will only prolong a crisis. Now, where available, if oxygen fails to abort a crisis within those 30 minutes, the patient must seek medical attention because severe anemia and infection, including malaria and pneumonia, may be the cause of the crisis. Now, the patient is on admission. Patient is having shortness of breath. The easy thing to think is that the patient is having an acute chest syndrome because you listen, you're hearing reels. But one of the common complications of admission, which I want to mention here, is fluid overload. In Gatman et al. 2021 stated, intra-IV fluid is routinely used in the treatment of vaso-occlusive crisis, but sickle cell disease is complicated by diastolic dysfunction and pulmonary hypertension, which in combination with the large amounts of IV oral fluid blood transfusion may increase the risk of fluid overload with pulmonary edema in patients with sickle cell disease. Pulmonary edema in turn can lead to an increased risk of acute chest syndrome, a potentially fatal complication. In fact, pulmonary edema is almost equivalent in terms of mortality with acute chest syndrome. So be on the lookout for fluid overload. Restrict your IV fluids, give Lasix, and have a high index of suspicion. An autopsy study in 21 patients who were hospitalized for vaso-occlusive crisis and died unexpectedly found that 15 patients had some form of lung pathology, and 47% of these patients had pulmonary edema. So again, this is a flowchart for shortness of breath during admission. You do your normal studies, CBC, chest X-ray. Those are the simple ones. The severe anemia, you treat, blood transfusion. If you're hearing rails, pulmonary edema, you treat, oxygen, IV Lasix, IV fluid restriction. If you're having acute chest syndrome, you treat, oxygen, IV antibiotics for community-acquired pneumonia. So again, in our case presentation over the last 20 years, we had patients aged from 25 to 67 years, excruciating pain scores of 10/10, occurring on average once every 2 months, with hospitalization once every 3 to 6 months. Majority of the crises occurring and waking them from sleep, or when they visited cities at high altitudes. We prescribed an oxygen concentrator for them to use at home. They were advised to sleep with oxygen, 1.5 to 2 liters per minute by nasal cannula. Only when there are one or more triggers, increased anemia, stress, exertion, infection, sedation, alcohol, cold environment, feeling of being unwell. The absence of triggers, they do not have to sleep with oxygen. All of our patients were able to abort a crisis by administering oxygen at the first sign of the crisis. The only exceptions were when the crisis occurred outside the home or was induced by infection or hypothermia. So we were able to change the frequency of this crisis from once every 2 months with hospitalizations once every 3 to 6 months to a crisis of once every 6 months to 1 year, and hospitalization to once every 3 to 5 years. What was the cost of a sickle cell crisis? A 2021 study by Holford et al. Showed $1.5 billion in lost wages and productivity each year in USA, and $650,000 lost over the average working life of a person with sickle cell disease. And you must note, sickle cell disease doesn't just affect the patient, it affects the family. So the economic cost is not just for the patient, it's for the mother who has to take time from being in the market, being at work, to be in the hospital, the father. So it is a cost that spreads around. In 2019, the aggregate cost for inpatient stays for sickle cell disease in the United States cost $811.4 million, with an average length of stay of 5 days. And in 2013, Lanscott et al. Showed that the average life expectancy in 2005 was 42 years for females and 38 years for males. So we must change our paradigm from a reactive paradigm where we just treat a crisis to a paradigm based on prevention of a crisis. In 2016 in the US, there were 134,000 related inpatient hospital stays for sickle cell disease. Over 3/4 of these stays involved a pain crisis. 90% were for Black patients. And nearly all stays with the principal diagnosis of sickle cell disease involved the pain crisis, 96%. Now, there are several curative options now. We have gene therapy, Lyfgenia, Casgevy. Well, these cost $2.2 million to $3.1 million. They are not realistic. First of all, they require a lot of capacity. They can only treat like one patient. Each medical center can only treat one patient a month. And the company like Bluebird Bio can only treat 85 patients a year, 85 to 100 patients a year. We have 100,000 patients with sickle cell disease in America. If you're treating 100 patients a year, it will take you 1,000 years to treat the number of sickle cell patients we only have in America. The process is complex, time-consuming, and medical centers can only handle a limited number of patients because each patient needs intensive care. Compared to gene therapy, $3.2 million, an oxygen cylinder in Nigeria is about 150,000 to 200,000 naira, about $100. The refills are about $1 per week. A concentrator costs probably about $400, 650,000 naira, lasting 3 to 4 years or $2 per week. Oxygen is the cheapest, most affordable treatment compared to any medication for a chronic illness. For an oxygen concentrator, the specifications, it must have continuous flow. Pulse dose is not effective. Patient need 1.5 to 2 liters per minute just by nasal cannula. And the concentrator must have 90% plus or minus 3% purity across all flow rates. Avoid concentrators with low quality sieve beds that have decreased oxygen purity with higher flow rates. The sieve bed is what is the technology in a concentrator. Concentrator takes in air, the sieve bed absorbs nitrogen, and the rest of that air is oxygen. It's a very, very simple principle of how it works. In Nigeria, you need a concentrator with a rechargeable battery due to erratic power supplies. These are pictures of oxygen cylinders, pictures of home oxygen concentrators. These are concentrators FAA approved for aircraft that patients can take on board the aircraft. But we want the Nigerian government to mandate all airlines flying, especially airlines from the United States, to provide compressed medical oxygen for patients with sickle cell disease. Airlines like British Airways, Air France do provide compressed medical oxygen. But the airlines from the United States do not, and it behoves the Nigerian government, because Nigeria is the epicenter of sickle cell disease in the world, with 5 million patients with sickle cell disease. Now, people get concerned. Are there any deleterious effects from long-term use of oxygen? 2021, Ligoro et al. Concluded that long-term oxygen therapy administered from 2014 to 2019 was a safe and feasible treatment option for children aged 6 to 15 with sickle cell disease and chronic hypoxemia. Now, remember, we're using a nasal cannula. A nasal cannula at 1.5 to 2 liters per minute is just 28% oxygen. We breathe in 21% oxygen. Everybody has been breathing in 21% oxygen during the duration of this presentation. So a nasal cannula is really, it does not have any long-term deleterious effects at all. Intervention, in conclusion, intervention with home inhalational oxygen can prevent and in the golden hour abort a sickle cell crisis. It must be made available and accessible to the estimated global population of 7.74 to 20 million patients with sickle cell disease and a sickle cell mortality burden of 376,000 in the year 2021. As Hippocrates stated in 400 BC, let food be your medicine. Sota Omoigui, I declared in 2024 AD that the guiding principle in the management of sickle cell disease shall be, let oxygen be your medicine. I'm going to just give you quickly to round up some of the patient testimonies of the use of this oxygen. Because no matter what the theory is, no matter how many randomized controlled trials you do, the final proof is the patients. The final proof is when the intervention gets into the real world. Here, this is a WhatsApp chat. Hi, Dr. Sota. This is the link. Send me a link for the oxygen concentrator this young lady bought for her brother. It allows the flow rates per your clinical guidelines and at an affordable cost. So I responded, thank you. How is your brother doing? You're welcome. He's doing great, thanks to you. No crisis since the oxygen. Prevented 2 this year. Then this one here, this is another patient. And actually, this is from the Sickle Cell Advancement Forum. Please, can you drop the Sickle Cell chat group and join link to the chat?
It's already in the box. I already dropped it in the chat.
Okay. Thank you. So people who want to join, please, the link is there. That's where I share all the information. This gentleman in the group said he went and got an oxygen cylinder. I said, oh, how are you doing? He said, thank you, sir. 3 days ago, the crisis surfaced as usual, and immediately we plugged oxygen on him. Before 30 minutes, he get fine and better, and he wake up very strong. This was the kind of case normally take us to hospital like 1 week before. Doctor, I love you, sir, for taking away stress. We've been going through all these years. May you live long, sir. Wow, it works like magic. So I said, the solution. The solution to a problem 7,300 years.
One lecture.
Please, can you mute your mic? Mute your mic.
Okay, no.
Okay. So now, again, these are the same patients. and asked him to send me a video testimony. He said, good morning, doctor. I am so grateful and honored by your invitation, sir. However, timing may be a factor. It may be a little difficult to join the meeting, sir. Like as I told you before, I'm based in South Africa, while my family is based in Lagos, Nigeria. And I'm a handy workman electrician, by the way. Sir, I discussed your invitation with my wife. She promised to do a video testimony. However, the oxygen has been a lot of relief to my family. Yeah, my boy was born 2005, very handsome and intelligent. He's growing up, no sign of sickle cell disease until 2022, when he gained admission to study medicine in Benin University. And after 6 months to 8 months of him in a foreign land, he started getting sick day in, day out. When they take him to hospital by the school, they will give him treatment and bill me. At the time, I decided to ask him to return to Nigeria to get proper treatment of the materials. When he come back to the hospital discovered that there was no blood in him. And they started running different tests. Let me go back to where it was. And then they found out that he had sickle cell anemia. So hold on, let me get here.
Hello, Dr. Omoigui, you should be rounding up, please.
Yes, I'm rounding up. This is the most important part. Okay. So they discovered that there was no blood in him, and they started running tests. They discovered the sickle cell anemia disease. This is how our problem started. Every week we're in hospital. He stopped going to school, crisis every month or 2 weeks. From that 2022, the problem was out of this world. No hospital who doesn't know my wife. And when this crisis started, they usually take 1 week or more to relieve him. If you are around him, doctor, you will cry. I don't think there's any pain greater than the pain of sickle cell disease. Doctors in Nigeria, some don't care. This is why my wife, with few of these doctors, fight. However, 3 months ago, I saw your advert through a town guy who's based in America that discussed the issue of sickle cell. And I followed him and called the guy, and he said he was going to contact you. And the guy's name is Tona. He called me back, gave me a link to follow, which I did, and followed your teaching. Initially, I wasn't understanding because I have issue of reading with understanding. And I kept on asking questions. That was because I was not following the teaching. I was thinking that there was hospital, you are going to refer us and we would pay a certain amount, you will get treated. Until a good lady that I'm still talking with this group called me privately and explained the whole thing about oxygen and gave me the address where to purchase, where I purchased immediately, and the delivery was made after payment. Now, whenever he has small pain, and my wife plugs the oxygen, which has been on medicine since 3 months, he will fall asleep. By the time he wake up, he will get better immediately. Sir, we're really happy with you. Ever since then, no going to hospital. He's big, he's fat. You will never agree that he was that person that was sick every week. Doctor will make time and do a proper video of this. He does everything people do. He drive, go out. He was telling me he wants to start an online business. So I'm going to make a proper video of this whole thing to encourage people about oxygen and the work side. The woman that chat my name is chat me. Her name is Yogo. I forget to insert her name. So that was it. Now these are the latest testimonials just in the last month. Good day, she'll be Dr. Sota. May God bless you real good. Please, my son has been using this oxygen tank since October last year. He has successfully combated 2 crises. Initially, he was skeptical about using it, but after using it twice, it really boosted his confidence and outlook towards life. Thanks so much. Last weekend, he had an onset of crisis and started using the tank. However, it was exhausted before he got relief from the pain. We had to resort to using pain medication. Thank God he wasn't hospitalized. We are considering buying a second cylinder as a spare. We can't afford the oxygen generator, which means the concentrator for now. This is another one. Good afternoon, sir. I just wanted you to know my son started complaining of pain this morning. I stopped him from going to school and had him use the concentrator, like that of the 78% purity for 2 liters. And after a short nap, he felt energized and better.
Your time is up, please.
Okay. So, hold on. Let me give you the last one. All right. So after a short nap, he felt energized and better. I think your discovery may be a major game changer, even though we are yet to get a better concentrator as prescribed by you. I'll keep you posted on his health and let you know how he's doing once I buy another one. I don't know what I'll buy for you, but if this works out the way I suspect, I will forever be in your debt. Okay, so that's the end of the testimony. I wanted to play a video testimony for you with a patient who used the oxygen concentrator. And I want to let you know the current paradigm that we have right now is MAD, M-A-D, which means medicine after death. The sickle cells have died. We are now chasing the complications. Patients are treated in a hospital after going into an irreversible sickle cell. The sickle cell crisis, whereby the irreversible sickle cells are dead. They need to be destroyed by hemolysis, while patients experience severe pain, severe decrease in their hemoglobin, multi-organ damage, and death. That is MAD, medicine after death. So what we need to do, we have shown this flowchart before, we must prevent the patient from progressing into this cycle of morbidity and mortality by stopping it where the sickling is reversible. So we've gone through this shortness of breath. So we must move from a reactive treatment approach of the last 100 years, whereby we wait for patients to get into a sickle cell crisis, experiencing severe pain and multi-organ damage and death, to a preventive symptomatic approach where home oxygen restores reversible sickle cells to their normal discoid shape and stops a crisis in the golden half hour, changing lives all over the world. Diabetes used to be a death sentence until the isolation of insulin by Frederick Banting and Charles Betts in 1921. We can make sickle cell disease a manageable illness just the way diabetes was, where home oxygen prevents and stops a crisis in the golden half hour. This was in 1921. This was the newspaper article with the discovery of insulin. We take it for granted now, but before this insulin was isolated and discovered, it was a uniformly death sentence. I have this poster. Helen, please drop this poster in the chat for people to use in terms of how to use the oxygen.
Okay.
Yeah, so it takes a village to bring a discovery to the world. I want to give an honorable mention to all of these who were involved in this discovery. Dr. Edwin Osahere Eribo, rest in peace. Dr. Noah Omoigui, rest in peace. Dr. Ogi Asemota, Dr. Tunde Asemota, Helen Omoigui, Isiwa Omoigui, Ifueko Omoigui Okaro, Dr. Abayomi Osunkoya, Dr. Anthony Kingsley, Megobede Uzi. I also want to mention Dr. Tunde Fakunle, who embraced this discovery and made invaluable contributions in sharing it with the world, as well as Professor Kolade Ernest, who also embraced this discovery. I have references here. Everything in this presentation, there's a reference to it.
I'd like to take that again.
So now I really want to show you how a concentrator is used. It's a very short video.
Dr. Omoigui, your time.
My time is up.
Your time is up, please.
Okay. All right.
Long ago.
Let me stop sharing. Hold on, please. Hold on. Okay. Have I stopped sharing? You see me now?
Yes, you have stopped sharing. Thank you very much. I know this cell is apparently a simple area, but it can get quite complicated. So I understand your pains not having enough time for presentation. I also appreciate the presentation, the lecture. I think on the chat box there are a lot of applause and commendation from friends and well-wishers. and a few questions, which I've tried to copy from the chat box. So if I can just, we have our 10 minutes, or probably less than that, for questions. I have about 4 questions here. So let me just quickly read the essence of them. One of them says that that liberal fluids is integral to managing sickle cell crisis. But as you mentioned in your presentation, that we have to be careful with fluids, which I agree with. So the question is, how do we strike a balance in the fluid administration to somebody who is having sickle cell crisis? So that's one question for you. The other one is somebody wants to know if the pain, the reduction that you are talking about is solely attributed to oxygen therapy, especially if you consider the fact that some of these patients are already on some other disease-modifying drugs for sickle cell anemia. So it's asking, can we empirically say it is the oxygen alone responsible for this reduction, or a combination of oxygen and the modifying therapy? And then the person also wants to know if there's any concern about rebound pain when oxygen is stopped eventually. Okay. I would also like to add another question, which is...
Excuse me, can I address them one after the other? Okay. Right. So first of all, in terms of IV fluids, you must have a high index of suspicion when the patient begins to have shortness of breath. In that case, you restrict the fluids, you give Lasix, and you don't just jump to the conclusion that it's an acute chest. Because yes, fluid overload will give you pulmonary edema and also give you acute chest. So just essentially what I say is, I don't have the specific formula, but just be cautious in your IV fluid administration. Remember that when you're also giving blood transfusion, you're adding to the fluids also. So just exercise caution and be ready to when you see shortness of breath, be ready to have that as a differential diagnosis. Now, in terms of oxygen with other disease-modifying agents like hydroxyurea, many of this, hydroxyurea does not stop a pain crisis. So the addition of oxygen stopped the pain crisis. So yes, oxygen can be used with hydroxyurea or without hydroxyurea. There are many people who cannot tolerate hydroxyurea. But the only thing that can prevent and stop a pain crisis in the golden half hour is oxygen gas. Okay, you can go to the next question, please.
All right, so actually this is my own question, but just want to know, because I have this funny mind, how are you able to secure your subjects in your determination of that golden half hour? I mean, when you consider the fact that sickle cell pain is very unpredictable. So I'm just wondering, how are you able to collect information in the first 30 minutes?
Well, you see, the unpredictable aspect you talk about is because people did not understand the contribution of nocturnal hypoventilation. So a patient goes to sleep, wakes up, has a crisis. You say it's unpredictable. No, it's not unpredictable. The patient had shallow breathing at night also had nasal vascular congestion due to the supine position, had nocturnal hypoxemia, and woke up in a crisis. There's nothing unpredictable about that. So yes, so the patient, and these studies have gone on for 100 years about nocturnal hypoxemia, about reversibility of a sickle cell crisis. So yes, we provided an oxygen concentrator to the patients, advised them to use it at bedtime, and we're able to stop the frequency of crisis. So there's nothing unpredictable. Unpredictable is when you don't understand why a crisis is occurring. And that's the whole reason for disseminating this discovery, is for people to understand that a crisis is predictable most of the time.
All right, thank you very much. The last question on the chat box is something like, what's the recommended oxygen flow rate for prophylaxis and therapy?
The recommended oxygen flow rate is 1 Yeah, 1.5 to 2 liters per minute. Patient can put it on. They can use it for an hour. They can use it they can use it as long as they want till they feel better. They can use it overnight. Always remember that what we are trying to treat is an hypoxic environment. So people say, oh, can there be hyperoxia? No, because it's like you're saying a diabetes, you're using insulin to prevent hyperglycemia. In a normal patient, insulin will give you hypoglycemia and give you serious problems. But in a diabetic, it brings your hyperglycemia back to normal glycemia. So the same thing in a sickle cell patient, it takes the hypoxic condition back to normoxic condition. So yes, 1.5 to 2 liters per minute, that's all that's needed.
Thank you very much. Well, I can see a hand online, but we ask people to drop their questions and comments in the chat box. But maybe I should just say, I don't know who is Omoigui Ehilaye. So just 30 seconds, please, if you don't mind. Omoigui Ehilaye, are you dropping your hand or you're talking to us? Okay, I think that hand must have been raised mistakenly. So I'd like to thank you very much, Dr. Sota. Omoigui, it's nice to talk to you. I'm sure that somehow we must have talked together some 44 years ago. So it's good to talk to you again.
Thank you. Same to you.
Well done what you are doing. We actually try to mount a study in Nigeria to see what oxygen can do regarding sickle cell pain. So I think you are giving us an importance to go ahead.
Thank you. And I want to mention that I do call on all or any of you to try to do your health outcome studies, try to do longitudinal studies.
Dr. Sota, sorry to interrupt. Can you hear me?
Yes, we can hear you.
Oh, yeah, please, very quickly. I'm so sorry. I pushed the wrong button, but I have these couple of questions that has been disturbing me. Each time I listen to you, I always want to listen to you all over again. It is as if you should not stop. 1 hour is actually not enough. Please, maybe next time, let's make it 2 hours so that we have enough time to listen to you extensively. You speak eloquently well. But here are my questions. Number one, with regards to oxygen nasal cannula, will you like to consider oxygen mask for the first 30 minutes in the absence of oxygen nasal cannula? Number two, do you think at this point your education should be included alongside cardiopulmonary education? Take, for instance, CPR, BLS classes, or even ACLS classes. Do you think this should be considered alongside these classes so that at the fundamental level, even students in high school that have parents or family members, siblings that have sickle cell or sickle cell disease, they will be able to understand how to manage this crisis at that fundamental level? Thank you.
Okay, thank you. Thank you, Omoigui. So, in the absence of nasal cannula, people can use a mask. A mask obviously is a little bit more restrictive. A nasal cannula will do the job. But if you don't have a nasal cannula, use a mask. And yes, there's a need for education of physicians, patients, not just in Nigeria, in the United States, all over the world. It should be included in the curriculum. This is a disease 7,300 years old. And this is a unique time for us to have a solution and offer a solution to this problem. And to make people understand that a crisis is predictable most of the time. During time, it's not predictable if there's an infection, a serious infection or serious malaria, but most of the time it's predictable, can be prevented, and can be stopped.
Thank you very much. So I think I have to take this last question because our elder is actually abiding by the instruction, which is to drop questions and comments on the chat box. So there's a question from Professor Nika Grinch. He said, congrats, Dr. Omoigui, for this groundbreaking discovery, which will be a game changer, especially in the developing world. In the developed world, where gene therapy is available. Okay. So the question is, will gene therapy free the patient from sickle cell disease manifestation permanently?
Good question. First of all, gene therapy will cure sickle cell, but any prior damage from sickle cell will not be reversed by gene therapy. If the patient already had a vascular necrosis of the hip, that will not stop it. If the patient already had the acute chain syndrome, lung damage, gene therapy is not going to reverse it. There's a patient who had a bone marrow transplantation, was cured of sickle cell, but because of the multiple acute chest syndromes and the multiple lung damage, that patient is still oxygen dependent today for even regular activities of daily living. So gene therapy will cure the sickle cell, but whatever damage, that's why even if a patient is going to use gene therapy, they must use oxygen to prevent them having any damage till they get to that point. But gene therapy, like I said, can only treat 100 patients a year right now for $3.2 to $2.2 million. With 100,000 patients in the United States, it's going to take 1,000 years for all the patients to have gene therapy. Now, unless there's a radical development in technology, which can always happen, but right now, oxygen is affordable and accessible in the global south as well as in developed countries to prevent and stop a sickle cell crisis. Let's stop waiting for patients to get to the hospital. By the time they get to the hospital, it's too late to stop the crisis. You must now start treating the complications.
Thank you very much, Dr. Omoigui. So at this point, we like to see that we have come to the end of what can be called a scientific session, which is really what it is. So I would like to yield the floor to Dr. Sendelechi to officially close proceedings. Thank you very much, Dr. Sota Omoigui.
You're welcome. Thank you.
Thank you, Dr. Sota, for your beautiful lecture today. We obviously all gained from it, and of course from the questions that it's obvious that this is a topic that will continue to excite a lot of us each time we hear about it, considering that Nigeria is the sickle cell capital of the world. And we will engage you further. Don't worry, there will still be more opportunities for you to present to us, particularly on this subject, because many more people will, because we're going to share the video, I'm sure a lot more people will ask us to call you back at some point. I want to thank Dr. Ogunride, one of the leading members of PAN and also the hepatologist. I'm sure you'll see a lot of sickle cell patients in Zaria. So well done to you and the sport team for looking after this patient. And just before we round up, I will call on Dr. Mubala to say a few words. Over to you, sir.
Yes, so thank you. It's been a very interesting afternoon. And thank you again, Dr. Omoigui, for very eloquently presenting such a very informative and thought-provoking subject, really. And it's the need for further education is very paramount, and so is the need to replicate these studies and observations in a tropical environment, because it's such a groundbreaking discovery that will require advocacy, and given the peculiar socio-economic and environmental situations in many developing countries, this will be very necessary to overcome inevitable constraints to its universal application. So I see this as the beginning of several meetings that you will be kind enough to host and to entertain in pursuit of this subject. It's been a very good afternoon. The house was full, and I'm sure there are many people on YouTube as well. It's a testimony to the presentation that we've had today. So I want to thank you very much again, Dr. Omoigui, and to Professor Ogunride for very ably moderating this session. Thank you, everyone, and good afternoon.
Thank you, everybody. Thank you very much to your group for for hosting this presentation. And again, I want to conclude by inviting all your physicians to do outcome studies before the oxygen and after the oxygen, longitudinal studies, not a clinical trial. We've already had a clinical trial done, and not a randomized controlled trial because it would be unethical to subject patients to a sickle cell crisis when we have oxygen that can stop it, but a health outcome trial before and after the oxygen. So please, those who are interested in working or creating a protocol, we're trying to create a universal protocol where we can document all of this before and after scenarios. So feel free to join the Sickle Cell Advancement Group. The link is in the chat group. And those who want to get further information, I share information on that group. But it's been my pleasure to present at this meeting. Thank you, everybody. Take care. Goodbye.
Thank you. Very much.
Thank you all. Bye-bye.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you. Thank you.
Bye.
Bye-bye.
Bye.